Schessler, Director of Education for Allergy and Asthma Network, and it's my pleasure to welcome you to Advances in Allergy and Asthma. This webinar series helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. It is presented in partnership with the American College of Allergy, Asthma, and Immunology. Today, we're joined by Dr. John Hagan, who will speak to us about urticaria and angioedema. And on our next slide, you'll get to see Dr. Hagan, even though you can't meet him in person. He's a consultant for the Division of Allergic Diseases in the Department of Internal Medicine at Mayo Clinic in Rochester, Minnesota. He also serves as an associate professor of medicine and has coordinated the internal medicine resident rotation through the Division of Allergic Diseases for over a decade. He is a fellow of the American College of Allergy, Asthma, and Immunology. Dr. Hagan's interests in clinical practice include clinical management of rhinitis, sinusitis, asthma, urticaria, angioedema, and anaphylaxis. Dr. Hagan, thank you so much for being with us today. We're looking forward to learning from your presentation.
Great, thank you. I have one disclosure. I'm a local primary investigator on a Shire DIAC study of lanadelumab in one of these angioedema conditions. And our learning objectives include recognizing a heterogeneity of various subtypes of urticaria and angioedema. This may modify patient care, augment our medical knowledge, and I work in a system and have a system-based practice approach to these topics. We also want to discuss some of the therapeutic modalities for treatment of chronic urticaria and angioedema. I'd like to begin with a case. Chronic stress hives presentation. A 49-year female presents to allergy clinic, actually the urticaria clinic, with acute onset facial hives, which began 6 years ago after a very stressful situation. But this key clue, antihistamines don't help. What's the real history? The patient perceives a prodrome with eyelid pruritus and tingling under the skin of the face and inside the ears. Redness, swelling, heat, and numerous whiteheads appear on the face, which can last up to a week. Afterwards, the skin appears to shed scales over the next few days. Well, some of us work in a very busy multi-specialty clinic, and it just so happens that day that the patient had already been seen by the dermatology resident before even coming to allergy. The patient was diagnosed with erythema telangiectatic rosacea. Of course, wouldn't you just diagnose that off the cuff? They had outlined a management plan, but it brings the question: could management for urticaria have been provided by me or someone in my clinic with this presentation? Because the patient had carried a diagnosis of hives for perhaps 5 or more years, but not had hives. So it's fundamental to go back to the basic diagnosis of urticaria, which means hives. And let's remember that hives or urticaria, hives represent raised, red, itchy, also pruritic, lesions, which do not sting, they do not burn or hurt, and they leave no scar. They also last less than 24 hours, maybe on rare occasion up to 48 hours, but generally not lasting greater than 24 hours. The raised area can have a central swelling of various size. This can histologically be the upper and mid dermis. They're more circumscribed or demarcated, and they have this erythema or redness to them. And remember, no sting, no burn, no scar, they don't hurt, and they last less than 24 hours. In contrast, angioedema is deeper. It is swelling of the lower dermis, subcutaneous or mucous membranes. It is non-pitting edema. The margins, as you see in this photograph, are not as well defined. It's typically not itchy. It's non-pruritic. Rarely it can be painful. The symptoms can last a few hours, but no more than 3 days at a maximum. So I've had lip swelling for 3 weeks now, and I've come to you for angioedema. No, no. 3 weeks of persistent swelling is not angioedema. The maximum amount of time would be 3 days. And so when I take a step back to consider, how do I think through working through cases that may have urticaria or hives or angioedema, and then keep in mind there are other types of rashes. I would tend to divide the hives or urticaria into hives that occur spontaneously, not necessarily by a trigger. Again, each of these lesions last less than 24 hours. That would get us into this urticaria diagnosis. And if urticaria lasts more than 6 weeks, then this will get us in the realm of possible idiopathic or autoimmune urticaria. This may or may not occur in the presence of coexisting angioedema. Spontaneous urticaria. And we contrast spontaneous urticaria with inducible urticaria. And some of these inducible urticarias would include a physical or local urticaria, something we can physically do to elicit or cause a hive. And then we differentiate this urticaria again from angioedema. And so let's go to the inducible urticaria and give some examples of physical urticaria. This is very common. Perhaps 3%, 4% of all individuals may have what we call dermatographic urticaria, also known as dermatographia, also known as dermatographism. You can take a tongue blade and stroke the forearm, or the patient may scratch their skin or back, and you see a linear wheel and flare reaction. You see it's raised, you see it's red, and the patient's going to describe it as itching. And this occurs after this stroke of a tongue blade. We elicit this in clinic all the time. Dermatographic urticaria, a physical inducible urticaria. Can you imagine working with a jackhammer, this vibration of your hands? And after working with that type, or maybe an old lawnmower where your hands shake, this vibration, this can cause localized hives. It's a physical hive, an inducible hive. And here we see in 2016, some authors, not us, but some authors described a genetic basis for some cases of patients who had vibratory urticaria. The same year we did have an interesting case, and this is an example of this vibration bed that somebody with apparently vibratory urticaria had spent some time on. This was a 53-year female with a history of hypertension on lisinopril. They were on this vibratory bed for 10 minutes, and during this time they developed diffuse pruritus, flushing, nausea and vomiting, pre-syncope. They actually went to the emergency room and they had hypotension with a blood pressure of 64/32. A serum tryptase was technically normal, but it was 8.29 nanograms per milliliter 8 hours after the reaction. They had 2 baseline samples, one around 3 and one just above 4. And if you put the math to this, take the baseline sample, multiply it by 1.2 and add 2, you can see that this tryptase of 8.29 was significantly elevated, confirming this is a systemic mast cell release phenomenon. This patient had anaphylaxis related to her predisposed state and lying on this vibratory bed. So a case of vibratory anaphylaxis. We think of cold urticaria. This would be a localized phenomenon. This would be an example of a physical or inducible urticaria. And we can elicit this by putting an ice cube on the arm, for example, for maybe 3 minutes, take it off, and then there is this wheel and flare reaction. meaning raised, red, itchy, just where the ice cube had been, a localized phenomenon. Now, I practice in Minnesota, and you've heard we're the land of 10,000 either ice or very cold lakes. I don't know if you've heard that part of it, but it's very important that somebody with cold urticaria not go swimming in a cold lake, because a person can also have a systemic reaction, a full-blown allergic reaction, anaphylactic reaction, if their whole body is submerged in cold water. Okay? And you can imagine if you're trying to replace somebody's mitral valve and you need to sort of do this cold type of anesthesia that they do in these cardiac procedures, this could be a problem. So this was a case report in 2018 when our cardiac anesthesiologist used this normothermic fibrillatory arrest in a patient with cold urticaria to successfully perform a minimally invasive mitral valve replacement. And in the anesthesia world, this would be a novel type of thing. I don't think they got my advice on the anesthesia part of this, but an example of physical urticaria. This is a very rare condition called localized heat urticaria. I remember this woman, we had her place an IV in the antecubital fossa. We then had her place her hand into a warm a glass of water. And where the water had been, there was confluent erythema, just like a glove, slightly raised, maybe 1 millimeter, and erythema over the whole hand, showing this phenomenon of localized heat urticaria. And at the time, I was working in Jerry Gleick's lab, who was at Mayo Clinic, Rochester, and we measured her blood for histamine, and we showed that after this cold exposure in the arm, there was this rise in histamine, followed by a local decrease in histamine over about 15 to 90 minutes, showing and confirming this was a mast cell or histamine release phenomenon. For some reason, serum tryptase was not elevated, at least in the study we did. Major basic protein is a marker for eosinophils. It was unchanged. We did not at the time see any significant change in something called eosinophil-derived neurotoxin, which was also an eosinophil marker. Localized heat urticaria, an example of a physical or inducible urticaria. And then there are other inducible urticarias. This is a unique one called cholinergic urticaria, when the whole body becomes too warm. Let's say I have on a significant amount of clothing and I exercise. I may become overheated. And in this general full body overheated condition, I may get these characteristic, very small, 2 to 3 millimeter wheals. There may be several on my skin. Then each of these wheals may gradually enlarge. We use the word they can coalesce. This can cover significant portions of the body. And again, this could, if in enough heat throughout the body, could result in a systemic reaction as well. Systemic cholinergic urticaria, an example of an inducible urticaria. Another case, a 63-year female nurse presents to urticaria clinic with a 5-month history of intermittent erythema and burning of her hands and feet. There is no swelling. Symptoms improve when she applies ice to her feet. Which of the following is the most likely diagnosis? This was a case referred by a dermatologist from elsewhere. Erythromelalgia. Remember, this did not fit our criteria. Remember, raised, red, itchy, no sting, no burn, no scar, and lasts less than 24 hours. We have experts at our facility in this condition, and so we referred it to our dermatologist, and we're happy with the care they provide our patients. IgE can cause localized contact urticaria. I think latex allergy may be the best example of this. And follow me, this gets a little technical because latex can cause at least 3 different phenomenon that I have on this slide. What I'm now speaking about is an inducible contact urticaria, where if I had on latex gloves, if I was latex allergic, my hands could break out in hives from the local contact urticaria. I remember this was a big deal in the 1990s. I had a colleague who was a respiratory therapist, and he was out on an ambulance coding someone, but he himself had latex allergy. And while he was coding someone, getting them up into the ambulance, he had on latex gloves. And he not only had hives on his hands, but he also developed anaphylaxis himself while trying to code the other, get the other person in the ambulance. Okay, so latex allergy can cause localized urticaria on the hands, contact urticaria. Latex can cause anaphylaxis, latex anaphylaxis, but there's some people who have no IgE or type 1 hypersensitivity to latex. They don't get hives or anaphylaxis, but way over here, they can get contact dermatitis. You can have contact dermatitis to latex and have no IgE-mediated allergy or acute symptoms with hives. You can have hives without dermatitis, or you can have both hives and dermatitis to latex. So this can get sort of complicated. This is an example of an IgE-mediated allergen, nuts and peanuts. And this is the paradigm of type 1 hypersensitivity, whereas we get peanut or latex that can combine with an IgE antibody, which resides on a high affinity IgE receptor on top of a mast cell. This is highly diagrammatic. Mast cells are one of the cells that can release histamine along with leukotrienes and tryptase. And with these mediators, we can, with histamine, have a wheal, the raised area, the red flare, the itching. We can have our hive as a skin symptom of this contact allergen. In contrast, as in the latex example with anaphylaxis, a person can get systemic symptoms from histamine, which can also cause nasal congestion, rhinorrhea, wheezing as respiratory symptoms. There may be cardiovascular symptoms with intravascular fluid loss, vasodilatation, resulting hypotension, in other words, a low blood pressure. And when the blood pressure goes low in an allergic reaction, the heart rate increases with tachycardia. With a systemic allergic reaction, there can also be gastrointestinal side effects, and histamine could cause nausea, emesis, and diarrhea. So these are symptoms which we in-house call the histamine review systems. And if we're thinking of somebody may have a systemic allergic reaction, we may be thinking of the histamine review systems to document that. Back to spontaneous urticaria. Allergists spend a lot of their time dealing with many individuals who may experience chronic urticaria, characterized by the other features of urticaria plus a duration of at least 6 weeks. Now, it could be a little confusing. An individual hive should not last in the same location for more than 24 hours, but you may have hives in one location today and tomorrow in a different location, 6 hours later in a different location. So these hives that come and go in various locations, and some people may last 6 weeks, and in some people may last for years. Some of these patients may have what we call idiopathic urticaria. Some may have autoimmune urticaria. If urticaria or hives are associated with angioedema, there is a phrase we use called angioedema with urticaria. Angioedema comes in different flavors, but if angioedema comes with coexisting hives, this typically is histamine mediated and typically falls into this category of angioedema with urticaria. Historically, treating this condition can be very challenging. A 41-year female neurosurgeon presents to urticaria clinic with a 2-month history of daily urticaria. Remember, red, raised, itchy, no sting, no burn, no scar, less than 24 hours. So we're going to accept this one as hives. Life is fine except for her husband, an accountant who seems stressed recently. She has a history of a bilateral tubal ligation. Her symptoms are improved on cetirizine 10 milligrams daily, which she takes in the evening. Cetirizine has approximately 14% chance of somnolence, but she's a neurosurgeon and she strictly denies any chance for somnolence. Use of cetirizine is not altering her thinking. She confirms that. But she has a few symptoms. Her weekly total UAS-7 score is 6. Her blood pressure is normal. Some baseline laboratory studies are normal. Which of the following is probably the most appropriate next step to consider? Making her satisfied may be as simple as adding fexofenadine, 180 milligrams, once daily in the morning. This would be a non-sedating antihistamine, and this would mean that she's on a total of 2 relatively non-sedating antihistamines. We would call those second-generation antihistamines. And so, when we talk about satisfaction in treating hives or urticaria, 20 years ago, I think there were a lot of people a whole lot less satisfied with us as physicians and providers, how we manage patients. So I am personally very thankful to people who write these guidelines. There's a more recent EACI, or European, and WAO, or World Allergy Organization guideline, published in 2018. And there is a previous 2014, I would call it here a US guideline in what we call JACI, or Journal of Allergy and Clinical Immunology. I would like to start over here with the EACI WAO guideline and to report that this is sort of the cookbook approach to treating confirmed cases of chronic urticaria. Again, we're on urticaria that's lasting more than 6 weeks and very bothersome. Just as in the case we showed, we may begin with a second-generation H1 antihistamine. We can keep on increasing this to 4 non-sedating antihistamines per day. And by doing this, we will achieve satisfaction in 45 to 65% of patients. If they're uncontrolled, we can add omalizumab. And from those who have been uncontrolled, gain 70 to 80% benefit. If we can't get omalizumab, we can alternatively use cyclosporin, which is an immunosuppressive agent and also achieves similar rates of satisfaction or efficacy. Now, the previous guidelines in 2014 would also remind us to avoid the physical triggers, which we discussed. We would recognize that maybe 30% of patients with chronic urticaria could be aspirin sensitive. That means they take an aspirin or Motrin or Advil, most non-steroidal anti-inflammatory drugs, and they break out in hives or get angioedema with that. H2 blockers were allowed in the 2014 guidelines, but give very little benefit. Montelukast would be a leukotriene receptor blocker, which could be added. There's a rare patient who could benefit from that, but not many. The 2014 guidelines allowed for first generation or sedating antihistamines to be used. We try not to zonk patients nowadays with the sedating antihistamines. And rarely, the 2014 guidelines allowed for use of prednisone, but hopefully very rarely. Next case, a 40-year male accountant, perhaps her husband, presents to urticaria clinic with an 8-month history of daily urticaria. Symptoms are uncontrolled despite cetirizine 20 milligrams twice daily, famotidine 20 milligrams twice daily, montelukast 10 milligrams daily, and already on omalizumab 300 milligrams sub-Q monthly with a weekly total UAS score of 40, which means not controlled. Blood pressure and laboratory studies are normal except for an undetectable blood basophil count and an elevated CRP during flares. Which of the following is probably the most important next step to consider? There could be different viewpoints on this, but one suggestion could be adding cyclosporin in the dose reported. And so, if we go to the end of the 2014 and the 2018 guidelines, we're on top medical therapy, we're already on omalizumab, I want to offer 3 considerations. One consideration would be in this 2020 article at the bottom on this side of the page. Of patients not controlled by either omalizumab or cyclosporin, combination of both together resulted in control in 76% of patients. So we'd prefer we have to use as little of medications as possible, but if someone is significantly not satisfied, they've got unrelenting hives on either omalizumab or cyclosporin, both could be used together with increased benefit. A second alternative approach, supported by several studies, could be increasing the dose of omalizumab above the stated 300 milligrams once monthly. This could be challenging for insurance approval. And the third, although not practical at this moment, I just want to report that perhaps hope is on the way, and I think patients tend to appreciate that. There are other agents being studied for chronic urticaria. This is an example of ligelizumab, which showed higher benefit in very uncontrolled patients, where omalizumab gave a 26% in a very refractory group for complete control of hives, and this dose of ligelizumab provided a 51% rate of complete control of hives. So sometimes these things may not yet be available, but still, hope is on the way. A 27-year female coach presents to urticaria clinic with a 4-month history of urticarial rash with burning, lasts up to 5 days. She has fatigue, mild anemia. She's on significant medications, including omalizumab, already 600 milligrams sub-Q monthly, with a weekly score of too high. Prednisone is the only medication which provides relief. Keep that phrase in mind. Requires prednisone. Nothing else helps. Which of the following is probably the most appropriate next step? And let me say that many allergists do their own skin biopsies at our clinic. We have dermatology do our biopsies for us. I think I gave it away. A dermatology referral for evaluation and skin biopsy. So I don't want to forget, if it's lasting more than 24 hours, in this case 5 days, if there's burning of the skin, if it's only responsive to prednisone, keep in mind urticarial vasculitis, which is going to have a different treatment protocol. Here would be a biopsy confirming urticarial vasculitis, which in this case would represent hypocomplementemic urticarial vasculitis with anemia, elevated CRP, low C4, increased ANA, and increased double-stranded DNA. Remember, raised, red, itchy, no sting, no burn, no scar, lasts less than 24 hours. If I have a correctable issue, this would be the focus of that correctable issue. I would like to shift gears and briefly discuss Andy with angioedema. 59-year male referred by primary care for concern over a 3 to 4 year history of recurrent angioedema, estimated at 5 times per year. He pulls out his cell phone, and nowadays people are showing us their angioedema pictures on their phone or device. He's on lisinopril. Let me break. Everyone with angioedema should be asked about lisinopril. If lisinopril is used or an ACE inhibitor, ACE inhibitors should probably be discontinued. And so his referring provider already felt that this was the cause of the problem. The patient strictly denies any food or medicines related to his symptoms. His medicine list, which I reviewed personally, included erythromycin with emesis. This was a medicine allergy list, and no other medications were concerning for angioedema. Diphenhydramine had been used, but no clear change in swelling. You explain why ACE inhibitors should be discontinued and are considering assessment of complement levels to exclude a coexisting acquired C1 esterase inhibitor angioedema. But before leaving the room, you're an allergist, or you work in an allergist office, and you ask him, does he have any seasonal allergies? Clear case at this point of ACE inhibitor angioedema. During my childhood, I had severe spring and fall allergies. I used to be allergic to cats. I sleep with a dog. Tell me more about. So an open-ended question about your allergies. When I eat apples, my mouth itches. When I eat hazelnuts, my tongue swells. Another open-ended question. Does anything else give you problems? Well, peaches, pears, plums, cherries, they all make my mouth itch. So, not all stories are straightforward. The history is very important. You'll find that allergists are probably some of the best history takers in all of medicine. This is a complicated case. I always stop ACE inhibitors in patients with angioedema. If they're not the primary cause, they could be a potential contributing factor. And so with angioedema, we have this concept we've already discussed, histamine-mediated angioedema, or angioedema associated with urticaria, or angioedema which may occur in the absence of urticaria. That raises the topic of bradykinin-mediated angioedema. And so in the green, ACE inhibitor angioedema would be a type of bradykinin-mediated angioedema. The presentation is different, and you need a good history to elicit the differences. Presentations for bradykinin-mediated angioedema include visible swelling, and it's typically in these locations: the face, the throat, the genital area, or the hands or the feet, and this may include abdominal pain. In this type of angioedema, there are no hives, there's no itching, and there's typically no response to antihistamines or steroids. In contrast, angioedema with urticaria, there could be some associated hives, and there usually are. There may be itching present, and there's typically some response, maybe incomplete, may not be as fast as you want, but some response to antihistamines and steroids. And keep in mind, there are different types of bradykinin-mediated angioedema, and we're going to walk through those in a few seconds. Regarding ACE inhibitor angioedema, in the ENT literature, 2017, I was struck by this point of a 105 patient cohort, and in that cohort, 6.7% of patients actually had a family history of angioedema. So for my allergy colleagues, I know we've got different groups on this talk, but for my allergy colleagues, could there be some hereditary features of these patients who we've been diagnosing as ACE inhibitor angioedema all this time? Could there be some genetic cofactors? A 60-year male presents to their emergency room with recurrent abdominal pain. Having listed a history of recurrent lip and periorbital swelling, although not currently present, the ER physician calls you, your colleague calls you, to ask how angioedema could be most efficiently diagnosed during the acute ER visit. This is a bit of a complex question, but in our mind here, this is the setting is the ER. There's a good ER physician trying to figure out why this patient has abdominal pain. And when going through the ulcer questions, the gallbladder questions, the emergency room physician notes that the patient has a history of recurrent lip and periorbital swelling. is there anything they could do in the ER to help determine if the abdominal pain were perhaps angioedema when there's no other swelling elsewhere and no hives elsewhere? I want to keep in mind that answer D was the correct one. A CT scan of the abdomen and pelvis can document bowel wall angioedema, and particularly in hereditary angioedema, in bradykinin-mediated angioedema that can involve the bowel wall. In my mind, this can be very helpful. So we see this CT abdomen showing bowel wall angioedema, which could help our colleague, the ER physician, in his differential diagnosis at the time. Symptoms described in previous attacks in 101 patients with hereditary angioedema, 100% had skin symptoms, but 97% had stomach or gut symptoms. 54% had laryngeal symptoms, could be life-threatening. Lesser had uvular and tongue swelling. I'd like to go on to a question. Which of the following is most consistent with hereditary angioedema type 1? If there are any allergy fellows on the call, this would be an allergy fellow question. So these are tests we would do commonly, and C would be correct. So in type 1 hereditary angioedema, there's this protein called C1 esterase inhibitor deficiency, and it's basically not there in this example. So the C1 esterase inhibitor antigen would be low. The protein's not there. It would not be functional since it's not there, and the C4 complement would also be low, but the C1q would be normal. This would be an example of hereditary angioedema type 1. A 25-year female presents to your ER. She was asymptomatic until some stress occurred at age 15 when she first noted hand swelling. She has had peripheral, abdominal, and now 3 pharyngeal attacks. She has other members of her family with hereditary angioedema, and here we see the low C1 esterase inhibitor, functional assay, and C4 complement, but a normal C1q. That would be the example of HAE or hereditary angioedema type 1. Which of the following is most consistent with hereditary angioedema type 2? In this situation, the protein is going to be there, but it's probably malformed, and because of that, it doesn't function properly. So, although the antigen level would be normal, the C1 inhibitor function would be low. The C4 would be low, but the C1q would be maintained. An example of this would be a 36-year female, onset of hands, elbow, feet, and abdominal pain swelling, while taking oral contraceptives, which can be a trigger with estrogen. Okay for a while when birth control pills were stopped, but later stress or manual work led to hand swelling that lasted 36 to 48 hours. She was now noting intermittent abdominal pain, and there was a positive family history of hereditary angioedema with the laboratory studies that we've described, a normal C1 esterase inhibitor level, but abnormal functional level and abnormal C4 complement. Again, the C1q is maintained in type 1 and 2 hereditary angioedema. This would be HAE type 2 in our figure. I would like to keep in mind that there are some angioedema mimics. Think of words called granulomatous cheilitis, Meckelson-Rosenthal syndrome. Think of the presentation of facial plethora, enlarged veins in the upper chest, SVC syndrome, uvular edema with snoring. Remember, the uvula is going to repetitively hit and have trauma during snoring. And remember, there can be other presentations where we think or we're concerned there can be throat swelling, such as paradoxical vocal cord dysfunction or dysphonia or laryngospasm. So keep in mind that it's good to see that cell phone picture For hereditary angioedema, keep in mind that there are some new treatments. We're very pleased to have these treatments. Anticipating the potential need for emergency care in a patient undergoing a second opinion for possible C1 esterase inhibitor deficiency, you recommend the patient go to the emergency room. But I've got a question, and this is for the allergist or the pharmacist on the call. Does our ER have these treatments, which are relatively new in the past decade or so, and will they be available for our hereditary angioedema patients if we do send them to the emergency room? I got caught up in this question within a year or so after these first came out about a decade or so. These are important questions. And so there are new acute treatments for hereditary angioedema, which were not present more than 15 years ago. And I will say, treatment of hereditary angioedema 20 years ago was very difficult. And I would say that the patients and the providers were not at all satisfied with our options. This is sort of a new world, and it's a much better situation for patients and also for providers. Here there are some acute treatments. C1 esterase inhibitor concentrate is a treatment. There's also a recombinant C1 esterase inhibitor. I will say back in the time we were involved in these clinical trials, I remember being up at night in a research center giving this agent or placebo to a couple of individuals. I remember a missed IV stick in one of these individuals, and then a good IV stick, and the IV stick that was missed then started developing swelling. And I could sort of tell that patient was really on placebo. In contrast, I recall someone who had been holding an emesis basin for perhaps an hour and a half, receiving this agent. And I know the studies say it takes maybe 20, 30 minutes, but within 5 minutes, the emesis basin was down, the nausea was resolving. We had a very good situation at the time, and I anticipate that was not placebo. FFP has been around for a long time, but there were some questions about would it benefit? Could there be any sort of reverse features to its action? There's a bradykinin receptor antagonist called icatibant, which is available for acute treatment. And for a number of years, there's been a kallikrein inhibitor available for acute treatment, but there's been some concern over anaphylaxis. And if you're having anaphylaxis with life-threatening angioedema, it's probably not the greatest situation. So I don't think that agent has had all that much use over time.
Dr. Hagan, we've got about 5 more minutes.
Great, thank you. And then we have the prophylactic agents. And again, I will say that 20 years ago, most of these things were not available. All we had was tranexamic acid and androgens, and this was not satisfying to either patients or providers. You're a 30-year woman, and now I need to tell you that you need to be on an androgen, or you're going to have life-threatening throat swelling. It's a horrible situation. So we're very pleased that C1 esterase inhibitor concentrate intravenously or subcutaneously, or a new biologic agent, or a newer oral agent, are available for use as prophylaxis in patients with hereditary angioedema. Which of the following is most consistent with acquired C1 esterase inhibitor deficiency? D would be the correct answer, and this would be the case of a 63-year male who has required tracheostomy due to recurrence of attacks. There's an underlying monoclonal B cell process which was proven on a bone marrow, and the key point to remember is acquired has a reduced C1q. So that ACQ acquired, you can remember the Q is the one where the C1q is low. So C4 complement, esterase inhibitor, functional assay, and C1q are all low in this acquired deficiency. I skipped over HAE with normal C1 esterase inhibitor. For me, it's been a very challenging situation. However, if somebody happened to have angioedema, if they were knowingly responsive to icatibant, which is a bradykinin inhibitor, then this would be the paradigm where a patient could be on that potential clinical trial. In summary, we've talked about urticaria. We've reviewed spontaneous urticaria, which has no clear trigger. Chronic urticaria is the prototype. And we went over a therapeutic algorithm supported by both 2018 European and World Allergy Organization guidelines and also the 2014 US guidelines, which are very similar. We've talked about inducible physical urticarias, and then we reviewed angioedema, both histamine-mediated and bradykinin-mediated angioedema, and we talked about some angioedema mimics. If you're an allergy fellow, then you should memorize this table so you can answer all the questions. And you should also consider, if you write down one of these diagnoses, you should be able to fill in the history of present illness, the family history, examination, laboratory results, and acute and chronic treatments which are available. Sally, we're ready for questions.
Wonderful. Oh, thank you so much, Dr. Hagan. There was so much information. I'm trying to take it all in. We do have some questions for you. Our first question is, what are some common triggers of urticaria and angioedema? Are there any triggers that can make symptoms worse?
So for causes, there can be inducible urticarias that have physical triggers. Physical triggers may include scratching the skin, such as in dermatographia or dermatographism, localized cold, hives, such as cold urticaria. Vibration can cause local hives. There have been reports of vibration-induced anaphylaxis. Heat in general or exercise and heat can cause cholinergic urticaria. And then in patients with chronic urticaria, aspirin or non-steroidal anti-inflammatory drugs can set off a flare of hives. In my experience, if you have a patient with chronic hives who've had them for quite some time and they've been reasonably stable, but they take a Motrin or Advil and they end up with angioedema in the emergency room, that's the story for aspirin sensitivity. Don't underestimate the frequency of people who can have aspirin-induced hives. For angioedema, triggers can include stress. You think about local trauma with the dental office. You think about estrogens in women as causes for hereditary angioedema.
Okay, our next question is, what is the impact of urticaria and angioedema on quality of life? What are some ways patients can manage their condition so symptoms do not cause emotional distress?
Quality of life, I think has radically changed, again, over the past, say, 10 to 20 to 30 years with this condition. I probably started in this 25, 30 years ago. And I think that we were all fearful of walking into a room with a patient with really bad hives. I just remember my desk, the patients on an interview bench, and Kleenex right in the middle. And I just remember sometimes we would start with the Kleenex before we ever got a word out on this history. So patients suffering with this have had horrible quality of life for many years. I think that's significantly changed. It's not perfect, but it's significantly changed. And again, I think we benefit when guidelines have been written and allergists are following these guidelines, which can improve quality of life for our patients with hives. Likewise, with angioedema, back 20 years ago, we were very limited in our options. Basically, for hereditary angioedema, androgens for prophylaxis. Horrible, horrible treatment with many side effects. We would spend the appointments monitoring for side effects. But there are novel agents which can substantially improve quality of life.
Thank you so much. Our next question is, how can we treat solar urticaria?
With solar urticaria, I would work with my dermatology colleagues, first of all, for diagnosis. With solar urticaria, there can be solar patch testing, and it can end up being a specific UV light spectrum that can be the cause of the solar urticaria. So in this phenomenon, there could be a specific, solar block used if people are wanting to go out of doors. And now, obviously, going out of doors if you have solar urticaria is going to be more difficult than if you don't have solar urticaria. It's like living in Minnesota and having cold urticaria. These are very challenging issues. But I think it gets down to a specific wavelength of the sunlight. This can be confirmed with help with our dermatologist, and sunblock, avoiding the sun are typical ways to help manage that condition.
Okay, I have one humor. Someone's got a sense of humor tonight. She said, everything is itching from us talking about urticaria. So I thought that was a fun comment. We have a comment, next question from a school nurse. She says, what type of intervention does a student require with a history of asthma that presents with cold urticaria?
Can you repeat that question?
What type of intervention does a student require with a history of asthma that presents with cold urticaria?
I think the question would be, do we consider that the same phenomenon, or we think of that as two different issues? Okay, so I would consider asthma first by itself. Does the patient have asthma? And we would generally think likely, but sometimes it's good to confirm that. Asthma could be diagnosed by what are the symptoms? Coughing, wheezing, shortness of breath, chest tightness. There's generally response to albuterol. At times, let me say that in my mind, asthma should be confirmed with reversible bronchial obstruction with a spirometry, and we commonly would use a methicillin challenge. An exhaled nitric oxide can be also used to help confirm some airway inflammation associated with asthma. So assuming we're really dealing with asthma, then there are several different guidelines over time which have clarified how we as allergists or respiratory physicians or physicians in general should manage asthma, and we would want asthma controlled in that situation. Okay. Now, for cold urticaria, we may use antihistamines, okay? And I think the concern would be, what if somebody with uncontrolled asthma went swimming in a cold pond? So I think you would apply this concept to, what if anybody has uncontrolled asthma and they have some systemic allergic trigger? You could use the same concept for peanut allergy. If somebody has peanut allergy, or let's say cold urticaria, and they're somewhat at risk for having a whole body cold exposure, then histamine in your body, if you have no asthma, is not going to be as apt to cause wheezing. If you have asthma and your asthma is controlled, histamine is going to be less likely to elicit bronchospasm. What you really want to avoid, and is very important, is having someone who is walking around daily with uncontrolled asthma, and they either get a systemic cold exposure, or let's say they eat a peanut and they're peanut allergic. That combination of histamine or allergic reaction in an uncontrolled asthma situation is a risk for a bad outcome or a concerning outcome. Okay. I don't know if you follow what I'm saying, but if there are any additional questions, I'm happy to to answer that.
We have time for one more question. And
Yes.
this question says, this sounds like there are multiple treatments that can, multiple options for treatment that can occur in these situations. Is there a shared decision-making aid you use in your clinic? And do you use a quality of life questionnaire?
We use the there are more than one scoring systems. I was using the UAS7 sort of in this talk, trying to get that as an example out there. The higher the score, the more uncontrolled. I tried to weave that into some of the questions to get people answering that question. On a practical basis, let's say if I had a patient with really bad hives, in today's world, if they're going to need omalizumab, the insurance company may require that the control of the hives is documented. They have to be significantly uncontrolled to go to a different level of agent. So if you're on maximal medical treatment, then your UAS scores are significantly high, UAS7 scores, then the insurance company would be more likely to help provide needed medications such as omalizumab. Okay, so that can be very important. Throughout time, you may can tell from the presentation, but I use shared decision making in virtually all of my activities. We do not currently use a specific regularly used among all providers tool for shared decision making in each of these levels of care.
Okay, well, thank you so much, Dr. Hagan. We really, you've shared such great information with us this evening, and we're grateful you took the time to be with us tonight. So I'd like to also thank our listeners for being with us. Please, at this time, please download that certificate of attendance from your control panel. If you have any difficulties, please email us using the link in your emails. And on the next slide, you'll see that you can join us next month for a special webinar with Dr. Marissa Shams, who will present on eosinophilic asthma, medications, and management. This webinar will air on Thursday, April 29th at 3 p.m. Eastern Time. You can register for this webinar on our website at allergyasthmanetwork.org. Look for news in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our recorded webinars on this page on our website. Dr. Hagan, if you could advance the one more time, please. Thank you. Visit our website for quality guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network, working each day to breathe better together.